Good afternoon, everyone. Welcome to this webinar entitled Neuromusculoskeletal Ultrasound for Peripheral Nerve Entrapment and Nerve Injuries, presented by Mohini Rawat. The AIUM is accredited by the ACCME. This webinar is designated for 1 AMA PRA Category 1 credit. By the conclusion of this webinar, participants should be able to understand the differences in peripheral nerve sonoanatomy for different nerves and same nerve at different sites, understand the nature of compression neuropathy and value of ultrasound in differential diagnosis, and know the role of ultrasound in differential diagnosis and assessment of nerve injuries, compression neuropathy, or other nerve pathologies that can present like focal compression. As an ACCME accredited provider, it is the AIUM's policy to ensure that the contents and quality of this activity are balanced, independent, objective, and scientifically rigorous. All individuals who are in a position to control the content of an educational activity are required to complete a disclosure form. All disclosures are reviewed by the AIUM, and any conflicts of interest are resolved or managed prior to an activity. Mohini Rawat and Darcy Belito de Luna have no disclosures. At the conclusion of the webinar, you will be able to access the CME test and evaluation located on the AIUM website. Participants who complete the post-test with a grade of 70% or higher will be awarded 1 CME credit. For more information on accessing the CME test and claiming credit, please refer to the handout provided in the dashboard on the right side of your screen. Credits for this webinar are approved for physicians, sonographers, and radiologic technologists. During today's presentation, if you have questions for the presenter, you may type them into the question box on the right side of your screen. You will be able to submit questions throughout this webinar, but the presenter will not begin answering until the end of the presentation, at which time she will answer as many questions as possible. A recording of this webinar will be available on the AIUM website. And now I'm pleased to present Mohini Rawat.
Hello, everyone. I'm happy to be here again. This is the second webinar, and this webinar builds on the webinar I presented last year. So it has a lot of information that I am going to present, and more information on the content I presented last year. So let's start by saying I have no disclosures. And Darcy already covered the objectives, but I just still wanted to talk a little bit about what we are trying to accomplish with this webinar today. We're going to start with peripheral nerve entrapments and peripheral nerve sonoanatomy and internal architecture one more time, because I think that is a very important point to understand why peripheral nerves appear different in echo texture at different sites. Even the same nerve can appear different as you scan and trace the nerve through the course of the nerve, and that is because of the sonoanatomy and the internal architecture of the nerve. We're going to review some of the compression neuropathy, physiology of compression neuropathy, and scanning techniques of some of the potential regions where nerve can get entrapped, followed by nerve injuries and traumatic nerve injuries, and role of ultrasound in assessment and differential diagnosis, and as an important adjunct to your electrodiagnostic studies. So ultrasound is a great tool for peripheral nerve imaging, because most of the peripheral nerves run a superficial course. Even the ones which are deeper can be easily studied with ultrasound, and you can follow the course of the nerve, and the fascicular pattern of the nerve can be studied in much greater detail. Compared to MRI, with ultrasound, you can see subtle changes in echo signal or echo texture, or notice the nerve dimension changes compared to MRI, and sometimes these subtle changes signal the early compression neuropathy, which are sometimes missed with electrodiagnostic studies, EMG studies. So ultrasound is great in cases like that. And it is a real-time evaluation, so we are looking at the nerves and the surrounding structures, and you can also talk to the patient and have a clinical correlation of your findings right then and there. And it is a great adjunct to EMG NCS studies for peripheral nerve, and you get a great structural perspective about the type of nerve injury or nerve entrapment. So the fascicles in the nerves are arranged either in plexiform form or cord-like manner, and depending on where you're scanning it, the fascicles may form the plexus or may be arranged in a cord-like parallel fashion. So in general, when you start from proximal to distal, you'll see that the fascicles are more plexiform-like, and as we go distal, they become more parallel to each other. So that's a cord-like arrangement, and that's a plexiform, which you can also see here. This is cord-like, and that's the plexiform type. And plexiform and cord-like arrangement can change the fascicular pattern that we see on the ultrasound. So fascicular anatomy, like honeycomb appearance or steinite appearance, can be different for the same nerve depending whether you're proximal on that nerve or distal on that nerve. So let's do a quick review of the connective tissue layers of the nerve. So the most outermost connective tissue layer of the nerve is epineurium, followed by perineurium, which envelopes the fascicular groups, and the internalmost connective tissue layer is endoneurium, which covers or envelopes the axon, individual axon. So from inside out, we have endoneurium, perineurium, and epineurium. And there is blood vessels within these connective tissue layers inside the nerve. So other than these three important connective tissue layers, epineurium, perineurium, endoneurium, there's another layer outside the peripheral nerve, which is called mesoneurium. And mesoneurium is a loose areolar connective tissue and also has blood vessels in this layer. So the arrangement of blood vessels is not straight. For the simplicity, most of the figures that you see a straight parallel arrangement of the blood vessels, but these blood vessels have a tortuous course. So as the limb is in, as you're moving the extremity in flexion or extension, nervous tissue allows some elongation and shortening. So when nerve is elongating, these vessels straighten or unfurl, and when they go back to their to shortening, they again furl. So by this tortuous arrangement of the blood vessels, blood supply to the nerve is not compromised, even if we are going through the extreme range of motion of the joints. And connective tissue layer is also not consistent throughout the course of the nerve. So if we let's start from the nerve roots. So nerve roots have 6 times the collagen than does the spinal cord, and compared to nerve roots, as we have peripheral nerves going into the extremities, the collagen content is 5 times more than the nerve root. So roughly 50% of the weight of the nerve is connective tissue layer. So, and connective tissue layer is very important in maintaining the integrity, protecting the axons and the myelin, and also maintaining the blood flow. It maintains a blood-nerve barrier within the nerve. So nerve is bound by epineurium and delimited by areolar connective tissue, which is mesoneurium. And when there is limitation of the joint or any other pathology where this excursion of the nerve is compromised, there is traction or compression on the nerve, that alters this blood-nerve barrier. So that this figure here explains the barrier system of peripheral nerve. So we have epineurium, perineurium, and endoneurium. Between the epineurium and perineurium, there is a diffusion barrier, and the capillaries, the small blood vessels inside inside the endoneurium, there is a blood-nerve barrier maintained by vascular endothelial layer of these blood vessels. So when there is compression, this blood-nerve barrier is compromised, and because of this compromise, there is increased permeability of endoneural blood vessels, which leads to endoneural edema. And because of the edema, there is increased endoneural fluid pressure, which causes further obstruction of the vasculature, which goes like a vicious cycle and leads to the injury of the nerve fibers. So prolonged pressure can injure the nerve fibers, can displace the myelin and cause demyelination and damage to the axons within. And when there is compression, on ultrasound, we see hypoechoic swelling of the nerve. So the nerve become enlarged, proximal and distal to the site of compression. So this is an example of median nerve, and you can see the fascicular pattern is somewhat lost. There is hypoechoic swelling of the nerve. In long axis view, we can see the swelling proximal and distal to the site of compression, and there is physical constriction at the site where there is maximum pressure. So this is the presentation with any type of nerve entrapment. Now, if you scan any nerve, you're looking for any hypoechoic signal and hypoechoic swelling of the nerve and the site of compression with loss of fascicular pattern. Now, to summarize what other changes are happening when there is a nerve compression or entrapment neuropathy, there is endoneural edema, which appears as hypoechoic swelling of the nerve. Inflammation gives you the same hypoechoic swelling of the nerve. There is distal axonal degeneration, which is also called Wallerian degeneration. As with more chronic compression, there is fibrosis, remyelination, where the nerve is trying to heal itself and remyelinate the area which are demyelinated, and there is thickening of perineurium and endoneurium. So in chronic nerve compression, we see more of connective tissue changes, where the connective tissue layers are more thicker and there is still loss of fascicular pattern. Now, in the last webinar, we covered first three entrapment syndromes. The most common entrapment syndrome in human body is carpal tunnel syndrome, and we covered carpal tunnel syndrome, scanning techniques, cubital tunnel syndrome, and tarsal tunnel syndrome in the last webinar. So I'm going to focus on the scanning techniques for other potential entrapment sites, like ulnar nerve entrapment at the level of Guyon's canal, posterior interosseous nerve syndrome, anterior interosseous nerve syndrome. Another name for anterior interosseous nerve syndrome is Killow-Nevin syndrome. Then Wartenberg syndrome, which is another name for entrapment of superficial radial sensory nerve, and suprascapular nerve entrapment. So suprascapular nerve can be entrapped at suprascapular notch or sphenoglenoid notch. These are the two areas where the suprascapular nerve can get entrapped. Followed by peroneal nerve entrapment or common fibular nerve entrapment at the fibular head or lateral knee. And the last is lateral femoral cutaneous nerve entrapment. Another name for it is Meralgia paresthetica. So let's start by scanning technique for peroneal nerve. So peroneal nerve or common fibular nerve branches out from sciatic nerve and on the posterior aspect of the knee, and it wraps around the fibular neck, as you can see here. So to scan this nerve in short axis, you keep the probe transversely across the neck of the fibula, and you see the nerve as hyperechoic structure because it's traveling between the fascial glands. Here it appears to be more flattened compared to other areas like median nerve, which is not flattened by any fascial bands. So that's how peroneal nerve appears in short axis view or transverse view. In long axis view, once you locate the peroneal nerve in short axis, you rotate the probe 90 degrees to see the peroneal nerve wrapping around the neck of the fibula. So this is the long axis view of the peroneal nerve, and that's the short axis view. Now let's scan the nerve. Let's start from the fibular neck where we see the peroneal nerve and go proximally to see peroneal nerve joining the tibial component and forming the sciatic nerve. So that's peroneal nerve. Now I'm going proximally, and that's the sural communicating branch. It joins that. Now they are both joined, and now it's going to go, and because it's going deep, the nerve appears more hypoechoic. And here's the tibial component. Now peroneal and tibial component join together to form sciatic nerve. So you can follow peroneal nerve at the fibular neck and go proximally to see the tibial component and sural communicating branch. So most common sources of compression in this site are space-occupying lesion like ganglion cyst, or it can also be caused by prolonged bed rest, where your head of the area where on the lateral aspect of the knee is pressing against some structure, because you have atrophy, you've lost a lot of subcutaneous tissue and muscle tissue, and you are more prone for compression neuropathy because the nerve is traveling right over the bony part, fibula. Okay, the next nerve is lateral femoral cutaneous nerve, and this is a sensory nerve which supplies anterior lateral aspect of the thigh. So if there is compromise of this nerve, there is complaint of numbness, tingling, abnormal paresthesia on the anterior lateral aspect of the thigh, proximal thigh. Now, the lateral femoral cutaneous nerve is deeper to the inguinal ligament, and it's the most lateral structure in this inguinal region here. Beneath the inguinal ligament, there is iliacus, there is femoral nerve, femoral artery, there is femoral ring, and pectineus muscle and psoas major muscle. So three muscles: iliacus, psoas major, pectineus. And if we go a little bit more distal, you also see sartorius attaching from ASIS. So that's a transverse section, and this this is anterior view. You can see lateral femoral cutaneous nerve, which is L2, L3, originates from L2, L3 inner roots, and it travels laterally over the psoas and anterior to the iliacus, and travels underneath the inguinal ligament and gives innervation to anterior lateral aspect of the thigh. So when you scan the lateral femoral cutaneous nerve, we put the probe transversely, bridging the ASIS. So the bony prominence on the left is ASIS. Now it's important to note that because it's a very, very small nerve compared to the femoral, which is more medial, and it's a sensory nerve and very small. And another factor that makes it a little bit difficult to visualize here is because it's between the two tight fascial bands. So the nerve is between fascia lata and fascia iliaca. If you can see these two white fascial layers here, so it's sandwiched between these two tight fascial layers, and it appears as a hyperechoic flattened oval structure, like you can see here. And in long axis, you see it as a small, very thin nerve, which doesn't have a very clearly defined margins like bigger nerves like median and ulnar nerves in the upper extremity. So this is the long axis view of the nerve, and that's the short axis. So we first obtain the short axis view, localize the lateral femoral cutaneous nerve, and then move the probe 90 degrees to go long on that area. So let's look at the short axis view. So I am on the ASIS. Now moving medially, you can look at the inguinal ligament here, and that's the femoral artery. Now go back to ASIS again, and now you have to do some tilting of the probe to localize a oval structure between the two tight fascial layers, fascia iliaca and fascia lata. And here we see the nerve. And I decrease my depth, and I'm using a high frequency probe, so you can see it a little bit bigger, bigger nerve here. So once you localize the nerve at this level, you go long on it slowly, and you can see the nerve elongating, and you see a thin band right just medial to ASIS. So that's the lateral femoral cutaneous nerve in the long axis. Okay, let's move on to the next one. Now let's look at the suprascapular nerve and the scanning technique. So suprascapular nerve originates from C5, C6, has C5, C6 innervation, and it travels posteriorly, going through the suprascapular notch and sphenoglenoid notch. And as it travels, it also gives off some articular branches, superior articular branch and inferior articular branch. So gives some branches to the AC joint, subacromial bursa, coracoacromial ligament, and inferior branch gives innervation to posterior joint capsule. Superior branch innervates infraspinatus and it innervates supraspinatus right off the suprascapular notch, and as it travels distally, it innervates infraspinatus here. So this is the superior view of the shoulder, looking at the course of the nerve. So nerve courses from suprascapular notch to sphenoglenoid notch in this direction. So to scan this nerve, we want to palpate coracoid process and move medially in the same axis as the coracoid process to be over the suprascapular notch. So in this view, I have a clavicle, and that's the notch here, and that's the suprascapular nerve, and that's the blood vessel. And if you turn the color Doppler on, you can see the blood vessel with the color flow here. So that's suprascapular nerve in suprascapular notch. Now going to the second area, which is sphenoglenoid notch. This is the area. So what we do is we scan the posterior glenohumeral joint and move the probe medially obliquely to be on the the sphenoglenoid notch. And this is the sphenoglenoid notch, and the hyperechoic structure that you see here is the suprascapular nerve, and there's an artery deep to it. So because there's an artery deep to it, you can see the nerve much clearly in this notch, sphenoglenoid notch, compared to suprascapular notch. So let's look at the video clip and the scanning technique to scan suprascapular nerve in sphenoglenoid notch. Let's go back one more time here. Okay, so we are on the posterior glenohumeral joint. Okay, I'm going to stop right there. Okay, so this is glenoid, this is labrum, that's head of humerus, and this is the glenoid part, and that's the head of humerus, and overlying muscle here is infraspinatus. So I'm transversely across posterior joint, and I'm going to move medially to be on this sphenoglenoid notch to get the suprascapular nerve. So now moving medially, and now you can see the groove in this area, the notch, and you can see the hyperechoic bright structure. That's the suprascapular nerve. Now going to upper extremity in the forearm, there is posterior interosseous nerve, which is a motor branch of radial nerve. So radial nerve in front of the elbow, anterior to the elbow, divides into posterior interosseous nerve and radial nerve, and posterior interosseous nerve then travels between two heads of supinators, superficial and deep, and it innervates the extensors of the forearm except extensor carpi radialis longus and brachioradialis. So to scan this nerve in short axis, you keep the probe transversely on the anterior aspect of the elbow, and you can see in this elbow at this level the nerve is already has already branched into two components. That's the posterior interosseous, and this is the radial sensory. And in long axis, that's the posterior interosseous nerve, and it's going to enter between the two heads of supinator, superficial and deep. Now, there's a slight variation. Whenever you're scanning a patient with, whenever you're scanning a nerve which branches from a main trunk, the branching pattern can differ from person to person and patient to patient. So, like in this clip, I'm again short axis on the nerve, and you can see the nerve is more or less looks like a single trunk here. It's all the fascicle are together. They are not separated or have not branched yet. Now, as I scan distally, you can see one part going superficial and other one, I'm going to hold it right there. So this is superficial radial sensory, and that's posterior interosseous nerve, which is going between superficial and deep head of supinator. So that's a muscle, and it's sandwiched between superficial and deep head of supinator. And if we continue distally scanning the nerve, we'll lose the posterior interosseous, but you can still see this superficial radial sensory nerve. So it's good to be aware of different branching pattern of these nerves, which are coming off the trunk of main big trunk of nerve, like radial nerve or median nerve. Now, going on the medial side, anterior interosseous nerve. So what we do is we start again lateral, and you can see the radial nerve and vessels. Now you move medially, and there's brachial artery, and next to the medial to the artery is median nerve. So that's the main trunk of median nerve here. Anterior interosseous nerve is a motor nerve which originates from the main median trunk, and it divides from main median nerve at approximately 4 to 5 centimeter distal to the lateral epicondyle. So here you can see the anterior interosseous nerve dividing, and because this nerve is traveling between two heads of pronator teres, and there's other fascia like arch of flexor digitorum superficialis, because of the fascial tension, this nerve can get entrapped, anterior interosseous nerve, and it gives you the presentation of this compression is purely motor with very little pain, and these people have difficulty flexing the DIP because there are three muscles that anterior interosseous nerve innervates: FPL, radial FDP, and pronator quadratus. So let's look at the nerve. So that's main median nerve, and you can see it's starting to branch out already a little here. And as we move the probe distally to scan the nerve, you can see that's the main median trunk, and that's the anterior interosseous. It's a smaller nerve, so to be exactly short on it, you have to lose the good visualization of the median nerve. Now in the long axis view, you can see the main trunk of the median nerve, and that's the anterior interosseous branching. And here the focus is on the anterior interosseous nerve, so you can see the nerve very nice and clear. And after that, it innervates different muscles here, so it branches off, and it's hard to follow in long axis. Let's look at the main trunk of the median nerve. It's flattening, branching, and that's right about here is the small anterior interosseous branch. Other than the fascial tightness and fascial tightness, which can compromise this nerve, there can be space-occupying lesions like aneurysm, ganglion cyst that can cause compression at this site. Now, going distally, following the radial sensory, we already saw that in proximal and followed it a little bit. So radial nerve divides into two branches, motor and sensory. The motor is posterior interosseous nerve, and the sensory is superficial radial sensory nerve, and you can follow it from anterior aspect of the elbow all the way distal at about approximately 9 to 10 centimeter proximal to the styloid process, or in the wrist joint. This nerve becomes superficial. Till that point, it is traveling between different muscles, fascial planes of the muscles, and at about 10 centimeter above styloid, it comes superficial between extensor carpi radialis longus and brachioradialis. So here is the superficial radial sensory nerve coming superficial. So this is skin, and at this level it becomes superficial and branches into different branches to innervate dorsum of the hand. That's the short axis view of the nerve right at the level where it's becoming superficial, and that's the probe orientation where you find the nerve which coincides with this area. So this is the potential, this is this area where you would see any focal changes in dimension or echo texture of the nerve. This is the site of compression between brachioradialis and extensor carpi radialis longus. And like I said, this nerve can be followed from elbow down. So we're going to follow this, and I'm going to show you that's the nerve that's in the proximal forearm. Now we're going scanning this nerve distal, and you will see this nerve starts to come superficial. I'm circling around this, hovering around the nerve. It comes superficial, and right at about this level, it's becoming superficial, and it's coming out between two muscles, which is brachioradialis and extensor carpi radialis longus. And as it comes superficial, you will see it flattens and it branches into terminal branches to innervate the dorsoradial aspect of the hand. Okay, now ulnar nerve at the Guyon's canal. So ulnar nerve enters the hand through the Guyon's canal, and to scan this nerve, you have to put the probe transversely across the pisiform on the medial aspect. You can see the transverse carpal ligament is on the floor of it, and there's a volar carpal ligament which has been cut in this image. Ulnar nerve is always closer to the pisiform bone, followed by the ulnar artery, which is radial to it. So here in this image, you can see the ulnar nerve. Because this is a high frequency probe, you can actually see different fascicles, but this structure is not fascicle, that's a blood vessel. And again, the size of the artery can vary. You may see bigger artery in some wrist and smaller. Here the artery and one fascicle of the nerve are almost about the same size, so they appear same. So if you're measuring this nerve and you're doing a side-to-side comparison, you may overestimate the cross-sectional area of this nerve if you don't know this is the artery. So you always want to use the color Doppler because nerves are always traveling with blood vessels, and you want to know which ones are veins and arteries. And sometimes the size of the vein and artery can be about the same size as one of the fascicle of the nerve. So here again, we are looking at ulnar nerve at the Guyon's canal, and you can see that's the nerve, and you can measure the whole thing, maybe not include this. But here in this wrist, the red arrow is pointing at the artery, the blue arrows are pointing at the vein. So this is these are blood vessels, all three of them, and this whole structure here is the nerve. With probe pressure, putting some pressure with the probe, you can obliterate the veins, and you can see you can no longer see the veins on either side of the artery, but you can still see the artery, and you can kind of see the thick walls around it. So now after the probe pressure, we know that this is the nerve, that's the ulnar nerve, and that's the ulnar artery. So it's important to use some probe pressure, transducer pressure, color ultrasound, color Doppler to define the margins of the nerve and to understand the fascicular anatomy of the nerve at this level. In long axis view, that's the ulnar nerve going over the pisiform bone, just actually medial to it, radial to it. First structure immediately next to the bone is the ulnar nerve, followed by the blood vessels. Okay, now let's look at the classification of nerve injuries. So this is Sunderland classification. Degree of injury, degree 1 is neuropraxia, where there is some involvement of the myelin. There's a pressure, and myelin layer, myelin sheath can be involved or may not be involved, but axons are intact and all the connective tissue framework is intact. So epineurium, perineurium, and endoneuriums are intact. So axon and their connective tissue layer is intact. Myelin may or may not be affected, maybe displaced, may not be completely eroded from that area. Grade 2 is axonatomesis, which is further divided into 3 more grades. So grade 2 axonatomesis, there is involvement of the myelin and the axon. However, the connective tissue framework is intact, and the TNLs in this case is positive for that nerve. In grade 3 axonatomesis, there is involvement of myelin, axon, and there is endoneural disruption. In grade 4, there is myelin, axon, and more connective tissue framework gets disrupted. So in addition to endoneural, from grade 3, there is now peroneural connective tissue layer which is disrupted. And grade 5, which is neurotomesis, there is complete severance of the nerve, and so there is no myelin and no axon, and all the connective tissue layer has been disrupted. And this is the grade which definitely requires surgical intervention. In fact, depending on several other factors, even in the third and fourth grade may also require surgical intervention. Now there's a 6th grade introduced by Susan McKinnon, who is a pioneer in this field, and if you are you're practicing and seeing patients of peripheral nerves, you're probably aware of that. She's one of the pioneer. She has introduced grade 6, which is various pathological changes, which means that some of the fibers in the nerve, part of the nerve may be grade 3, grade 4, grade 5, 1 or 2. And you can see this better in this next slide. So this is Susan McKinnon's 6th grade of nerve injury, where the same nerve is undergoing different grades of nerve injury. So that's grade 1, where only the myelin is affected. Grade 2, where there's connective tissue layer and is intact, but axons are affected. And then grade 3 and 4, where even the connective tissue layers are disrupted. And 5, which is complete transection of the nerve. So you can still have complete transection of part of the fascicles of the nerve, but not the whole nerve. And that grade, that type of injury can be defined by grade 6. Now, whenever there is an injury, there is a neuroma that forms in that area. Now, so what are neuromas? Neuromas are pathological distension caused by nerve entrapment or trauma. And they result in dysfunctional to non-functional nerves. So there are neuromas, and that leads to non-functioning or dysfunctioning nerve, and that those are the symptoms of weakness or maybe atrophy or sensory dysfunction. And these neuromas are broadly classified into 2. One is continuous neuroma, and the second one is stump neuroma. So continuous neuroma is also called neuroma in continuity, where part of the nerve is severed and there's a neuroma that forms, but there are still some fibers connected, and that is called neuroma in continuity. Stump neuroma is complete severance, and there's the ends of the nerve form a bulbous neuromas on either end. So continuous and stump neuromas. Now, whenever there is an injury to axon, there is a Wallerian degeneration, which is degradation of axons and their myelin. So that's an intact peripheral nerve. So blue represent axons, and yellow is the myelin sheath. When there is an injury, there is loss of axons and the connective tissue layer and the myelin in that area, and that Wallerian degeneration sets in, and the proximal stump tries to send axonal sprouts into the gap, across the gap to the distal stump to try heal this site. And there are several factors that can hinder this axonal growth or healing process. And those are misdirected or non-directed outgrowths. So the fascicles which do not, so sensory fascicle into motor or motor into sensory, or the fascicle A into C versus going to A versus A fascicle going to the A fascicle of the distal stump. There may be overabundant scar tissue which can interfere with the nerve healing, and the overabundant scar tissue is basically proliferated fibroblast in that area. Or there may be a larger gap which is not easy to which is not easy for axonal sprouts to reach and innervate the distal or reach the distal stump. So all these factors, misdirected or non-directed outgrowths, overabundant scar tissue, and increased gap between the stump causes neuroma development. And neuromas can be of different types. And these neuromas are disorganized sprouting axons interspersed with proliferated connective tissue. So there are some tangled axons because of axon sprouting and scar tissue and connective tissue in that neuroma. So neuroma can be fusiform, it can be bulbous, or it can be a lateral neuroma. So this type of neuroma would form when there is injury to only one side of the nerve and there's a neuroma, lateral neuroma that has developed, or something like dumbbell, or this is also very similar or very close to the stump neuroma, which is the complete severance of the nerve. When this nerve is repaired, the neuroma is resected and the healthy looking fascicular pattern is revealed, and that nerve is repaired end to end. Now let's look at the normal cross-sectional anatomy of the nerve. So here you can see the nerve has very nicely defined fascicles here, fascicular group, and you can count them. There are total 9 fascicles here. On the right, there is partial transection of the fascicles. Some of the fascicles, you can still see some intact fascicles here, and part of the fascicles are severe. And the scar tissue has been removed to expose those healthy looking fascicular groups so that they can be repaired end to end, and so the nerve can heal and innervate the appropriate and correct end organ, which can be sensory or motor. Now let's look at the neuroma. So that's the example of neuroma, and if you slice this, you can see the scar tissue. This is thick connective tissue, and you don't see any fascicles. There may be some tangled up axonal sprouts, but it looks like a fibrous connective tissue compared to this healthy looking nerve where you can see nice fascicular groups. So let's look at some of the case examples to apply this information that I presented so far. So this first example is 70-year-old female with recent onset of wrist drop. This patient had severe arthritis of multiple joints, and multiple joints were swollen. But what the complaint that brought her to the clinic was recent onset of wrist drop, and the EMG exam showed very severe compromised neuropathy of right posterior interosseous nerve, which explains the wrist drop. And there was grade 4 fibrillation, positive shock waves, and no evidence of active motor urinary action potential. So this is advanced focal entrapment neuropathy of posterior interosseous nerve. Upon doing ultrasound, there was more information that was revealed. So in cross-sectional, you can see a big mass on the anterior aspect of the elbow, and in long axis, you can see this big mass compressing the posterior interosseous nerve. So there is almost thinning or very much thinning of the nerve superficial to the mass, and proximal to that there is increased hypoechogenicity of the nerve. So here the posterior interosseous nerve was not a primary syndrome, it was secondary to a mass which was synovial chondromatosis. Now, next case, this is a female, 56-year-old female who presented with numbness in the ulnar aspect of fourth digit and fifth digit and clawing of the hand. And she had these symptoms for 3 months, and she had a surgery for right elbow fracture, open reduction internal fixation. So there are symptoms of both sensory and motor dysfunction because she has clawing here and she has numbness tingling. So EMG showed very severe compromise of her ulnar nerve at about the elbow, and there were grade 4 fibrillations in ulnar innervated muscles and no active motor unit potential. So that's a very severe ulnar neuropathy at the elbow. So we know that with the EMG there's a severe neuropathy, but ultrasound can add more information. So looking at this nerve, so this is a long axis view. So that's the distal ulnar nerve. This is medial epicondyle, and that's proximal. So you can see right about at the level of medial epicondyle, the nerve is tethered in scar tissue. There's a dense fibrous scar tissue. You can also see some tiny hyperechoic signals, which is some foreign bodies, or maybe because she had fracture in that area, maybe some small loose bodies in that area, but the nerve is trapped here in scar tissue and tethered to this area because of this dense scarring. And this, although the nerve is continuous, but because of this scarring and injury to this site, there is no motor unit potential in the distal extremity, and there's clawing. Upon doing, so she was a candidate for surgery, and she received the surgery. She had this surgery to release the nerve and reconstruct the nerve. The nerve, you can see the neuroma. The nerve looks very disorganized. It's focally thick, and there is dense scarring in the area, which is cleaned to a certain extent in these two pictures. And after the nerve was repaired, you can see the nice looking nerve in this view, and there's a wrap around the nerve. So here the nerve has been cleaned, and it was repaired with the allograft in this area. Now, contrasting the previous case of ulnar neuropathy, status post ORIF, forming a neuroma and dense scarring around the nerve. The second case is again a patient presenting with ulnar symptoms, but he's a young patient who also had a fracture, comminuted supracondylar fracture, and there was a lot of hardware in that area, K-wire and screws and plates, and there was a lot of hardware in that area. And he also had clawing of fourth and fifth digit and numbness tingling. There was no motor unit action potential observed. So the EMG was more or less the same for this case and the last case. However, the ultrasound gave us a different picture for the second patient. So here you can see the screw here next to the ulnar nerve here, and this is at the level of medial epicondyle. Like you can see, this is the probe placement for this view, and going slightly proximal, you can see nerve enlargement, but this is not. This is just a neuroma, and there are no fibers intact here. In long axis, you can see the fibers proximally. There's a lot of edema that you can see in the subcutaneous tissue. That's medial epicondyle, and you can see the nerve distally looks more or less uniform, but at this area there is complete transection. There are no nerve fibers intact in this area. So this is inflamed the mesoneurium and outer fibrous bands that hold the nerve in place, but there are no nerve fibers in this area. So this is complete transection. This patient also had a non-healing ulcer on the olecranon, and that's because of the hardware which was not letting the skin heal. So because of this, the results of these exams, ultrasound and EMG, the surgeon decided to do end-to-end repair, site-to-end repair in the forearm. So medial antebrachial cutaneous nerve to ulnar motor, and sensory fascicles from the median nerve in the forearm were transferred to the ulnar to give the protective sensation and strength in ulnar innervated muscle. So the area in the elbow was not repaired. The repair was in the distal forearm to speed up the healing, because if the nerve does not grow fast enough to reach the end organ, the surgery may be failed. So the surgery was done to repair and do the end-to-end transfer, side-to-end transfer in the distal forearm and not in the elbow region. And another reason was because intraoperatively the nerve stimulation in the elbow region did not produce any muscle contraction. So now the next case is neuroma and continuity, and this neuroma is pure sensory neuroma. So this is a patient who had a who was in a fight and was assaulted, and he had a sharp object knife hit his radial side of the fourth digit, and he presented a couple of months later, 6 to 8 months later, and he had a area on the radial aspect, very tender. That area, if you press there, it would give him lancinating pain, and upon doing ultrasound, you can see sudden enlargement of the radial digital nerve, the digital nerve on the radial aspect of the ring finger. So that's a neuroma of the sensory digital branch of the fourth digit in long axis. In short axis, you can see the neuroma on radial aspect of the digit. That's the flexor tendon. So this is the transverse view. That's the flexor tendon. So on the ulnar side, you can see the normal looking digital nerve, and on the radial side, the digital nerve is big, and that's because that's the site where he has neuroma, and he had excruciating pain, and he was very sensitive to touch in this area. So this neuroma was repaired with, this was reconstructed with allograft. And this is just an image to show intraoperative image how a neuroma looks. So this is a neuroma of the lower extremity. This is the sural nerve, and you can see there's sudden bulbous enlargement of the nerve. So that's the sensory nerve, and there's sudden bulbous enlargement of the nerve. And sensory neuromas are very painful. Okay, now the next case is a patient who presented with again ulnar symptoms, numbness, tingling in fourth and fifth, which was not so his main complaint was not numbness and tingling. He had more weakness in the hand, and that happened after he had a crushing and laceration type of injury 3 months ago. He had atrophy of first web space. His manual muscle testing for ulnar innervated muscles, first dorsal interosseous and abductor digitorum minimi, was 3 on 5. His 2-point discrimination on median innervated second digit was 5 millimeters, and ulnar innervated fifth digit was 6 millimeter. So sensory exam was not too bad. So he had some sensory involvement, but not significant, although he had significant involvement of the motor component of the ulnar nerve. So there was clawing of ring and fifth digit. There was atrophy and weakness of ulnar innervated muscle, and his EMG showed partial axonal injury of the nerve, and there was a complete conduction block of the ulnar nerve. And there was, although there was some evidence of motor unit potential, so that's a good sign that he will recover because of the partial axonal injury, although there were signs of denervation with reduced recruitment, but motor unit potentials were observed. So looking at the ultrasound of this patient's wrist, so the blue line that you see here shows the area where the laceration was. So this is where his laceration was, and you can see the scar tissue. So, and the time he presented his, there was no open wound. The laceration was healed very well, although you could see on ultrasound the scar tissue penetrated the ulnar nerve in the Guyon's canal. So that's the ulnar artery, and that's the whole nerve. And the scar tissue was right about at the level of the ulnar side of the nerve, which also coincides with the motor fascicles. So the topography of ulnar nerve at the wrist at the Guyon's canal is arranged in a way that motor fascicles are on the ulnar aspect, and these are sensory fascicles. So this ultrasound exam explains why patient has more motor involvement than sensory involvement, because the injury, the penetrating injury, the scar tissue is on the motor aspect and affects the motor fascicles, and sensories were not affected as much, although he has some conduction block, which of course is understandable considering there is a scar tissue and there will be some compromise. So ultrasound correlates with the clinical presentation of this patient very well. Now, this is an example of Meralgia Paresthetica. We reviewed the scanning technique, and here you can see the normal side where you can see the thin hypoechoic band. Of course, there are tight fascial bands, so you see the nerve as a very thin hypoechoic, relatively hypoechoic band with hyperechoic borders. And on the involved side, affected side, you can see diffuse swelling and enlargement of the lateral femoral cutaneous nerve in this region. So whenever the nerve is abnormal, even those hard to scan nerves, when they are abnormal, they are much easier to see. So these hard to scan nerves, in the beginning when you're trying to learn to scan and you find you're having a hard time, it's important to invest some time to understand the anatomy and their relationship with other structures and localize them. But when they're abnormal, they're very clearly visualized. Okay, I think this is the last case. This is again a patient who presented with ulnar neuropathy at the elbow, and in this case, because this is a chronic case, I just wanted to point out how chronic compression appears. So you can see the hyperechoic signal around the nerve. So the connective tissue layer is thick here. Right at about this level where there is compression of the nerve, there is a little bit of focal deformity, hourglass deformity, and this corresponds with this short axis because you can see this hypoechoic mass underneath. This is a small cyst coming from the ulnar, from the elbow joint, compressing the ulnar nerve, and proximal to the compression, the ulnar nerve is enlarged and hypoechoic, and there is loss of fascicular pattern, and same is true a little bit more distal. And in this elbow, there is some cystic mass because there is some degeneration. There was also a rupture of posterior band of ulnar collateral ligament and little ossification here. Okay, so that was the last case, and we are just 2 minutes left, so I'll just quickly take some questions. Okay, I do see some questions here. So there's one question about what ultrasound system are these images taking. So there are two different, but I'm not sure. I don't think I can disclose that because that would be conflict of interest. So I don't think I can say the name of the brand of the ultrasound machine I can use, but these are there are many. I use a portable one, and there are many companies. There is you can find that out somewhere else. Okay, another question. In case of AIN, I had a patient in whom the ulnar on the right was visualized distal third, but it terminated at mid half of arm. He had symptoms of AIN neuropathy on the left. So I'm trying to understand the question. So the symptom was I'm not sure what the question is. So you were able to visualize the nerve, and but he had symptoms. I'm sorry, I don't understand the question. Okay, I'll take the next question. Is there any relationship between neuroma and skin pigments in children? I'm not aware of that. I'm not sure if there is any, but I know there is skin pigmentation with a condition like cafe au lait sign, which you see in neurofibromatosis. So there would be some correlation with the neurofibromatosis and skin pigmentation, but not sure about skin pigments and neuroma in children. Okay. Next question is we want to know the age that neuroma may occur. I don't think neuromas are age related. It's you would see them in injury or compression. So when you see them in compression, they are more like a pseudoneuroma, which you see sudden enlargement proximal and distal to the site of compression. And when there is an injury, that's because of fibroblastic proliferation and axonal sprouting in that area. Okay, now the next case is the role of physical therapy in this case. So I think it's a team approach. So you have to evaluate the case very well, see the structural perspective, and what are the findings of EMGs and ultrasound and the clinical presentation. If there was any other comorbidities and any injuries, and you manage that as a team, and you may have to involve other members of the healthcare. That would be beyond the scope of this webinar to comment on the role of just PT in this case. Okay. And so there's a question about how I got involved in this area. I think I'm just lucky enough to be surrounded by some really great people who inspire me. So we have some great board certified electrophysiology specialist, and I happen to work with a great team of surgeons and physicians who trust my work, and I learn every day from them. So I think I just happen to be in the right place to be involved in this area.
Okay, and we're going to have to call it a day with that.
Okay, great.
And thank you. And on behalf of the AIUM and the APTA, our thanks to all of you who participated today in our webinar. Please remember to complete the post-test and the activity evaluation. And we hope you enjoyed this presentation and will join us again for future webinars. Good afternoon, everyone.